All right, welcome back. In our next lecture, we will be discussing shock in terms of pediatric advanced life support. So in order to understand and treat shock, we first have to take a step back and define what perfusion is. So perfusion is defined as the circulation of blood through an organ system, or a part of the body to deliver oxygen and nutrients. And so shock is the state of inadequate tissue perfusion that results from the failure of either the cardiovascular system, meaning either the heart or the blood vessels, to deliver sufficient oxygen or nutrients to sustain vital organ function. So looking at the cardiovascular system broken down, we first talk about the vasculature. And so the vasculature is broken into different vessel types. The first type that carries blood from the heart is the artery. So arteries are conductance vessels, meaning they conduct blood away from the heart, which is freshly oxygenated. And then they come to the arterioles. And so arterioles are conductance vessels, but they also have the capacity to change the resistance of the vessel. So that means they can regulate how much blood flows to different organ systems to deliver blood where it needs to go and shunt it away from places where it doesn't need to go. Next, we have capillaries. So capillaries are exchange vessels. So they are very thin-walled vessels, about 1 cell thick in some places, and they allow the transfer of oxygen across the vessel membrane into the organ that is being supplied by that vasculature. And so they are necessary and crucial for oxygen delivery. And after oxygen is transferred to these vital organs, deoxygenated blood is carried away from them via the veins. The veins carry this deoxygenated blood back to the heart and back to the lungs for reoxygenation, but they're also serving as capacitance vessels, meaning they are a reservoir of blood, which can be called upon when the oxygen needs of the body are not being met and when the body needs to redistribute its blood in crucial ways. So first part of understanding shock is understanding what blood pressure is. And so blood pressure is defined by several different numbers. The first is the systolic pressure. So that is the high number that we see when we get a blood pressure measurement. The next is the diastolic pressure. And so that is the low number we see when we measure a blood pressure. And the difference between these two is known as the pulse pressure. And so the pulse pressure is significant because it can tell you what type of shock a patient is in some cases, and what the degree of their shock is. And so it's important to understand all these. In particular, of note, diastolic blood pressure is good to understand because we know that the coronary arteries that supply the muscle of the heart tissue, the myocardium, are perfused in diastole, or in the diastolic pressure. So if you have too low of a diastolic blood pressure, you may not have adequate tissue perfusion of one of the most vital organs in the body. So understanding that is crucial. Next part of understanding blood pressure is that it is determined by a couple things. It is determined by the cardiac output. So the cardiac output is the amount of blood that flows out of the heart in a certain time period. So cardiac output is calculated by multiplying the heart rate times the stroke volume. And so the heart rate is how many times a minute the heart is beating, and the stroke volume is how much blood is being pumped out of the heart with each heartbeat. So the next part of the blood pressure equation comes from vascular resistance. And so vascular resistance is essentially the resistance of those arterioles we spoke about, regulating the delivery of blood to different organs and causing the blood pressure that we see when we measure it with a non-invasive cuff. So we already spoke about the definition and the equation for cardiac output. It is assessed by the following. So cardiac output, as we said, is determined partially by heart rate. It determines your blood pressure to some degree in conjunction with your vascular resistance. And then another way to assess what your cardiac output is doing and what it looks like is looking at your end organ perfusion. And we'll get into that in our assessments. So stroke volume, as we spoke about earlier, is part of the equation for cardiac output. And so stroke volume is how much blood comes out of the heart with each heartbeat. It is determined by a couple things. So it's determined by the preload, how much blood is going into the heart during diastole, or the filling cycle, filling part of the cardiac cycle. It is determined by the afterload against which the heart has to pump. And so if there's higher afterload or higher resistance of those arterioles against which the heart is pumping, then the stroke volume will go down because it has to work harder to pump against that resistance. And then finally, stroke volume is determined by contractility. So contractility is essentially the amount of squeeze that the heart produces and how strongly that muscle is contracting. So knowing that children are different than adults, we have to sometimes calculate what the estimated circulating blood volume is for a patient who presents in shock. And so a general rule of thumb for infants is about 80 milliliters per kilogram of body weight. So this is proportionally smaller for children and adolescents. And in an adult, we can typically say a rule of thumb for a 70 kilogram adult, they have about 5 liters of blood volume, and that is circulated throughout their body. Now, this blood volume is subject to cardiovascular and physiologic reserves. And so we have some reserve capacity. Children have less so than adults. And so that is why children are more prone to rapid decompensation because they have less reserve than adults in terms of their physiologic reserve. So now that we've talked about the components of blood pressure and cardiac output and the definitions of shock and tissue perfusion, we'll look at different categories of shock. So the first category of shock is defined as compensated shock. So this is often an early type of shock where patients can have a somewhat relatively normal blood pressure. And so the patient's body may not be receiving adequate oxygenation to its vital organs. And so it's performing some compensatory responses in order to adjust for that. So it can increase your heart rate as a means of increasing your cardiac output. It increases your stroke volume to increase your cardiac output. And then it can increase your vascular smooth muscle tone in order to maintain blood pressure and maintain perfusion pressure of those vital organs. So clinical signs that a patient may be in compensated shock, including neurological changes such as restlessness, irritability, or confusion, all types of altered mental status. They typically will have normal systolic blood pressures in early compensated shock. However, you may notice a narrowed pulse pressure. So as we said, the pulse pressure is the difference between the systolic blood pressure and the diastolic blood pressure. So essentially what's happening is that diastolic blood pressure number is going up, making your pulse pressure narrower. And that's because your blood vessels are clamping down in an effort to maintain tissue perfusion and vital organ perfusion and keep blood flowing where it needs to go. Additionally, you may have a slight increase in your ventilatory rate, increased respiratory rate. You can have tachycardia as a means of increasing your cardiac output, as we said. And then you may start to notice subtle physical exam findings, such as weaker peripheral pulses. You can have pale mucous membranes, and that's essentially a sign that you're getting less perfusion to somewhat non-essential tissues. So your body is trying its best to perfuse heart, lungs, kidneys, liver, other vital organs, and then kind of shunting blood away from less vital organs, such as your mucous membranes. In terms of, end organ perfusion, kidneys give us a window into how well they're being perfused by making urine. So if you have a mild decrease in your urine output, that may be a sign that you have some degree of compensated shock. And then looking at peripheral vasoconstriction, you may have either vasoconstriction, meaning a patient is clamping down those arterioles and shunting blood away from the skin and the periphery to keep it internal and keep it towards the vital organs in the trunk. Or you may have vasodilation in certain types of shock, and we'll talk about that a little bit later on. So compensated shock, if you act quickly, can be reversible, but if it does not get corrected in a timely fashion, it can progress to the next category of shock, which we'll speak about. And that's known as hypotensive shock in the purpose of these PALS lectures. So it was formerly called decompensated shock, but essentially it means you've kind of crossed out of that compensated picture and your body's compensatory mechanisms are breaking down and you're really having a harder time delivering oxygen to vital tissues. So we'll talk about what the signs and symptoms of that are. So as before, you will have neurological changes or altered mental status, whereas before you had somewhat preserved systolic blood pressures and even elevated diastolic blood pressures, you may start to see hypotension or drop in these blood pressures. You'll certainly see an increase in your respiratory rate, and then these patients may start to tire out. They may have respiratory muscle fatigue or even failure. Certainly you all have increased heart rate or tachycardia because that's part of your equation for cardiac output as your body's trying to compensate. And then occasionally you can even have dysrhythmias or abnormal heart rhythms. So when the myocardium or the heart muscle becomes irritated because it's having to work too hard or it's an acidotic state, it can start to have abnormal heart rhythms, and we won't touch on that too much today. You will start to see weakness of your central pulses as opposed to just peripheral pulses. You can see delayed capillary refill, again, showing that your body is shunting oxygen delivery and perfusion away from your skin. And then you may have, again, paler cyanotic mucous membranes and decreased urine output. So hypotensive shock is, a little further down the road than compensated shock, and it is very difficult to treat, but it can be reversed if you are aggressive in terms of the therapies we'll talk about. So those are the categories of shock. Now we'll look at different types or etiologies of shock, okay? And so there's 4 main categories we'll discuss today: hypovolemic shock, distributive, cardiogenic, and obstructive shock. And we'll get into how those are all different from each other and then look at separate case scenarios. So first off, hypovolemic shock is essentially a state of inadequate circulating blood volume relative to the capacity of the vascular space of the blood vessels. And so in hypovolemic shock, you have decreased intravascular blood volume leading to decreased preload for the heart. And so that's the central problem in this situation. If you don't have enough preload, you're not going to adequately fill your ventricles. And then without adequate preload and ventricular filling, you will have decreased stroke volume. Even though your body tries to compensate, you eventually will have decreased cardiac output. And then finally, the end organ perfusion will suffer. You'll have inadequate tissue perfusion at the end. So hypovolemic shock really is dependent upon how much volume we've lost and how rapidly you've lost it. And that will kind of dictate what the signs and symptoms of shock are in this scenario. So the way we assess and treat these patients, you get a focused history, try to see what got them into this state. Did they have severe diarrhea? Have they had bleeding? Are they dehydrated from not drinking enough liquids? What's the scenario? And then you try to get some basic vital signs. You look at their pulse oximetry to see what tissue perfusion is and oxygen delivery. And then you put them on a cardiac monitor, get a non-invasive blood pressure. If there's any signs of trauma or external bleeding, obviously try to stop that if possible. Because shock is a state of decreased oxygen delivery to the organs, you try to give supplemental oxygen to increase the oxygen capacity of the blood. And then you will likely need vascular access in order to resuscitate these patients. So the way we resuscitate them is with isotonic crystalloid solution. So that essentially means normal saline, lactated ringers, and other things in that category. And we typically start with 20 cc's per kilo boluses. And after each fluid bolus, it's important to reassess how your tissue perfusion and your oxygen delivery is doing. You want to always check their endocrine perfusion in terms of mental status, their heart rate, blood pressure, capillary refill, their peripheral perfusion of their arms and legs, and their urine output. Now, if you're in a trauma situation, as we spoke about before, bedside ultrasound can be a useful tool if you're looking for internal bleeding in the chest, abdomen, or pelvis. And then other things that you can think about in terms of nutrient delivery alongside oxygen delivery can be glucose levels. You may want to check a glucose level to make sure this patient is not hypoglycemic. You'll certainly want to try to maintain a normal body temperature, keeping them normothermic. In order to track their urine output more closely, you may want to insert a Foley catheter. And then you kind of want to dictate your diagnostic studies depending on the clinical scenario, and that will help your workup down the road. All right, the next category of shock we'll look at is distributive shock. And so as opposed to hypovolemic shock, where you didn't have enough intravascular volume, distributive shock results from decrease or abnormality in vascular tone, which causes a relative hypovolemia. So when you have the beginning pathway on distributive shock is having decreased peripheral vascular resistance. So we talked about those arterioles have the capacity to change the resistance in your vascular system. And so when their resistance goes down or they vasodilate out, they can decrease the vascular resistance throughout your system. And so because you have these resistance vessels making your tank relatively bigger, you will have relatively less volume for the same amount of space. So you will have an end organ tissue perfusion problem, and your venous capacity will dilate out. You'll have more pooling in your veins, and then decreased venous return to the heart as a result. And then, as we spoke about before, decreased venous return to the heart means decreased preload. And so decreased preload is one of the components of cardiac output, and this is what gets you into a shock scenario. So distributive shock can come from several different etiologies. It can be seen in septic shock, or also known sometimes as warm shock. It can be seen with anaphylactic shocks, such as severe allergic reactions. And then sometimes in trauma situations where you have a central nervous system injury, any CNS injury can cause vasodilation through the CNS's control of the arterioles and vascular resistance. So those are the three most common etiologies we see in this category. All right, the next category of shock is septic shock. So septic shock has a wide range of manifestations, but they all kind of link back to a common pathway, which is a physiologic response to an infection or infectious organisms and their byproducts, meaning toxins that are sometimes released by this bacteria, that results in both cardiovascular instability and organ dysfunction. And so this is the most common type of distributive shock in children. So there are different kinds of septic shock. There's warm shock and cold shock, which we touched on earlier, and we'll speak about both of those. So in the early phase of septic shock, the clinical signs and symptoms may show you preserved blood pressure, but patients can sometimes have bounding peripheral pulses, which can throw you off somewhat. It may seem that they're having good peripheral perfusion, but the bounding peripheral pulses are actually because the patient is inappropriately vasodilated out, and they have this physical exam finding as a result. Similarly, they may have brisk capillary refill, or sometimes known as flash capillary refill. They may be complaining of chills. They may have subjective fever as a part of an immune response to the pathogen that's causing this. They may initially have normal urine output, and then they may have other signs of systemic inflammatory response, such as tachypnea or increased respiratory rate, and they may have warm and dry or flushed skin. They may appear somewhat plethoric. Now, when we move to the late phase of septic shock, they often have different findings, including altered mental status, as your end-organ perfusion of your brain is compromised. They can develop cool or mottled extremities. They can now have delayed capillary refill as opposed to flash capillary refill. And they may begin to develop diminished pulses or absent pulses even. Their urine output will decline as their kidney perfusion goes down, and they will have tachycardia as their body tries to compensate by increasing cardiac output via that means. So there are several endpoints that we try to target when we're resuscitating patients with septic shock. And so things that we look for that we're doing a good job and we're resuscitating a patient adequately would include decreased capillary refill time. So less than 2 seconds is considered normal. You want to get their blood pressure back to normal if you can. You want their pulses to get back to normal, so not bounding, not absent or thready. You would like them to have warm and well-perfused extremities. And you want their urine output to get back to normal, greater than 1 milliliter per kilogram per hour. You'd also like them to have normal mental status, showing they have good brain perfusion. So the way we assess these patients, we obtain a focused history, and then of course we get vital signs and anthropometric measurements. So get the pulse oximeter on, get them on the monitor, get a blood pressure, and try to give them oxygen. We know that shock is a problem with oxygen and blood delivery, so optimize the oxygen content of your blood. Of course, you'll need IV access in order to give those fluid boluses. And then we want to give isotonic crystalloid solution, as we said before, either normal saline or lactated ringers at 20 milliliters per kilogram. Again, it's important to check things like glucose and calcium, as these are important cofactors for oxygen delivery and energy delivery to these vital organs. Because the cause of septic shock is usually an overwhelming bacterial infection, we often try to give antibiotics as early as possible. So giving them within the first hour is often crucial. And so we try to give broad spectrum antibiotics covering whatever the clinical scenario is for that patient, whether they've been in the community or in the hospital, or they have some sort of immune compromise. That all kind of informs what kind of antibiotics we need to give that patient. You will likely need a lot of vascular access if this patient is not responding to initial shock resuscitation. And so sometimes that takes the form of a central venous catheter or a central line. And that enables you to give vasoactive agents. And the most common ones we usually employ are norepinephrine, dopamine, and epinephrine. Now, some patients who present with septic shock do require an advanced airway or endotracheal intubation and placement on a ventilator. And that's not necessarily because they're hypoxemic, but rather it can be because putting a patient on a ventilator and on positive pressure ventilation actually decreases the afterload of their heart and can improve their cardiac output significantly. So it's an important technique to remember, even if your patient isn't profoundly hypoxemic, sometimes they need to be intubated for shock alone. Now, in order to decrease the energy needs of the body, we often try to keep these patients normothermic. And so we can use Tylenol or acetaminophen to keep their fevers down. We can sometimes use cooling blankets so that they're not over-extracting oxygen and we're not having to deliver more oxygen than necessary for these vital organs. Another thing you may want to check in terms of your secondary assessment is obtaining a cortisol level. So cortisol is kind of the master stress hormone for the entire body. And when cortisol levels are low and a patient has adrenal insufficiency, they're not able to mount an effective compensatory response to shock. So they sometimes need supplemental corticosteroids in order to compensate and survive shock episodes. So something that's important to check after you've done your initial resuscitation and assessments. All right, the next category we'll be looking at is anaphylactic shock. And so anaphylactic shock, as we touched on previously, is a kind of distributive shock caused by a severe and sudden allergic reaction. And in children, the most common causes are usually food allergies or insect bites, sometimes medications, and sometimes other things in the environment, such as latex. You can see this child here has a rash over her face. It's important to note that anaphylactic shock technically has to involve two organ systems. So you'll see rash, you'll see hypotension, you'll see GI symptoms, but there has to be two involved in order to meet the definition of anaphylactic shock. And so the way we assess these patients is, again, we perform the initial assessment. We try to remove the causative agent if we can. So if they still have the bee stinger in them, it's important to remove that to remove the stimulus for their shock. And then, of course, get them on the monitor, get their blood pressure and their cardiac monitoring done, and give them supplemental oxygen, as this can help with their shock state. The treatment for anaphylactic shock is intramuscular epinephrine. So this acts as a vasoconstrictor for those inappropriately dilated arterioles, and it is the first line and second line treatment for these patients. They may also need resuscitation and fluid resuscitation. So again, you'll want to get vascular access if you can, and we resuscitate them the same way with isotonic crystalloid solutions at 20 ml per kilo. Additionally, if they have other signs, other organ systems involved, including bronchospasm or respiratory compromise, they may sometimes benefit from bronchodilators or albuterol. And then secondarily, you can give them other anti-inflammatory medications to help stop this reaction. So sometimes they need diphenhydramine or Benadryl as an antihistamine. Sometimes they need systemic corticosteroids. And it's not uncommon to see these given in anaphylactic shock situations. All right, next we'll look at neurogenic shock. This is another type of distributive shock, which usually comes after a trauma or a CNS injury. And like other types of distributive shock we've talked about, it is defined by a widespread vasodilatory process. And so when you have widespread vasodilation, you have decreased peripheral vascular resistance, which is one of the main components of your blood pressure. And so when you have decreased vascular resistance, you have decreased venous return to the heart, and again, decreased preload. As we said, preload is one of the major components of cardiac output. And so with decreased preload, you have decreased stroke volume. So stroke volume goes down, and then your cardiac output, despite attempts to compensate by increasing your heart rate, will eventually go down. And when your cardiac output goes down, your blood pressure goes down, and that's one of the clinical signs we see when we're doing these assessments. When you don't have cardiac output, you don't have blood pressure, you have inadequate tissue perfusion, and that is the definition of shock. So inadequate tissue perfusion to meet the demands of the body. And this is coming from a CNS or central nervous system etiology in this scenario. So the ways we can determine if it's a neurogenic etiology sometimes can be found out from the blood pressures that we see. So whereas early compensated shock has a narrowed pulse pressure, neurogenic shock can often have a widened pulse pressure. So because you have that decreased vascular resistance, peripheral vascular resistance, as the common pathway here, you may have a low diastolic blood pressure. And so that will mean you have a widened pulse pressure. And so that's an important subtle sign that you can see that may indicate that this patient is in neurogenic shock. Because of this, they will have normal capillary refill as they're very vasodilated out. And sometimes their heart rate can be inappropriately low. So normally a patient in septic shock or hypovolemic shock will have tachycardia. But for these patients, because they have systemic reaction due to a CNS injury, they're not mounting that appropriate normal tachycardic response. And so their heart rate may be low or normal even. So again, thinking about them being vasodilated out, they may trick you because their skin may be warm, may be dry. They may not look malperfused. So the way we assess them is the same. We try to get a focused history, see if there was any trauma that precipitated this. If it is a trauma event, you always want to maintain cervical spine stabilization until you're able to have a surgical team or CT or x-rays to assess for any cervical spine injury. You'll want to check neurological checks as often as you can to make sure the patient's not having progressive CNS injury. And then you want to get basic monitoring. You want to have them on the pulse ox, the cardiac monitor, and blood pressure monitoring as well. So neurogenic shock, the treatment is essentially the same. It's still a variety of shock. So you want to get IV access. You need to administer isotonic crystalloid solutions for resuscitation. And then certain types of vasopressors may be more preferred in this situation than others. So because the etiology is more of a vasodilatory shock, one of the first-line vasopressors may actually be norepinephrine, as norepinephrine acts firstly and strongly on alpha agonists receptors. And so in order to treat inadequate or inappropriate vasodilation, you want to make those blood vessels clamp back down again. And norepinephrine is a good drug for that. Again, you want to make sure that the child's body temperature is normal, not too hot, not too cool. All right, next we'll move on to cardiogenic shock. And so cardiogenic shock is essentially a type of shock which results, as all types of shock do, from cardiovascular dysfunction. But whereas other types of shock had cardiovascular dysfunction in terms of vascular dysfunction or inappropriate vasodilation, cardiogenic shock means that you're having inadequate cardiac output as the main etiology. So we start here with the physiology of this process. So decreased cardiac output can come from many different reasons we'll discuss in a second. But if you have decreased cardiac output, you will have decreased blood pressure. We know that blood pressure is a product of cardiac output times systemic vascular resistance. So if this goes down, your body will try to increase your systemic or peripheral vascular resistance in order to compensate. And so this actually leads to kind of a vicious cycle because your systemic vascular resistance, or your PVR, goes up, and that increases the afterload that your heart has to pump against. And so the heart that's already failing has an increased afterload to pump against. It has to demand more oxygen to supply those heart muscle tissues. And so this leads to even worse decreased cardiac output. And again, that leads to decreased blood pressure. And as we said before, your coronary perfusion is dictated by your diastolic blood pressure. So if you have decreased blood pressure, particularly decreased diastolic blood pressure, you'll have decreased coronary perfusion pressure. And that leads to inadequate oxygen delivery to the heart muscle, and eventually the whole system will just shut down. You'll have decreased cardiac output, decreased tissue perfusion, and again, progressive myocardial dysfunction. So this can happen for many different etiologies. If you have abnormal heart rhythms, that can certainly affect the heart's ability to produce normal cardiac output. Any type of congenital or inborn heart lesions can certainly cause cardiogenic shock because of a structural problem. There can be inflammatory disorders or rheumatologic problems that affect your heart muscle's ability to function normally. And then other obstructive problems we'll touch on in a second. So the clinical signs and symptoms, as with many types of shock, you have essentially decreased end organ perfusion in many different ways. So you have altered mental status or inadequate brain perfusion. You can have cool extremities. You can have decreased urine output because your kidney perfusion is not adequate. One thing that is sensitive for cardiogenic shock is hepatomegaly. So hepatomegaly means large liver or enlargement of the liver. And so if your liver is enlarged, that can be a sign that your heart pressures the diastolic pressures are increased because you're not emptying the heart adequately. And so when your liver is distended and palpable below the ribs, that can often be a sign of cardiogenic shock. Of course, hypotension is a sign of late cardiogenic shock. Increased worker breathing is always a hint. Likewise, in addition to hepatomegaly, signs of cardiogenic shock can include pulmonary congestion. So if you're not emptying that heart adequately, or if there's left-sided dysfunction, the left side of the heart usually emptying the pulmonary circulation, you can have pulmonary edema, crackles, and congestion. Another way to look for that inadequate emptying of the heart is known as neck vein distension, or JVD. You're probably familiar with that term. So jugular venous distension in adults is a great way to see if you're having inadequate emptying of that heart. In terms of other poor endocrine perfusion signs, you look at for pale, mottled, or cyanotic skin. If there's any swelling of the legs or the upper body, inadequate means inadequate emptying of the heart sometimes. And then patients may have a history of poor feeding. They obviously won't want to eat well if their gut is not well perfused. Tachycardia is one of those compensatory responses we talked about. And then, of course, pulses are kind of the window into your cardiac output in the periphery. So the way we assess these patients, we just do a focused history, try to see if there's some medical problems that can contribute to cardiogenic shock, or if this is a new finding. And then we get them on the monitor. We check their oxygen levels, their cardiac monitoring, see if there's any arrhythmias, and then blood pressures, of course. You'll want to get IV access in order to resuscitate these patients. And to check for arrhythmias, it's important to get an EKG if you're worried about cardiogenic shock. For cardiogenic shock, sometimes we do rely upon invasive hemodynamic monitoring or peripheral arterial lines. We'll often need to obtain laboratory studies and diagnostic studies such as chest x-ray or even an echocardiogram to look at the function of the heart. Now, in severe cases, these patients may sometimes require mechanical support from extracorporeal membrane oxygenation, aka ECMO. So this is essentially a heart-lung bypass, which takes over the critical functions of the heart and lungs in patients with severe either pulmonary or cardiogenic shock. And often these patients will need pediatric intensive care level of support if they are this sick. All right, next category we're going to look at is obstructive shock. And so we've looked at different categories prior to this. We looked at hypovolemic and distributive shock, where you don't have enough relative or absolute blood volume to supply oxygen to the body. We looked at cardiogenic shock, where you don't have a strong enough pump in order to pump that blood throughout the body. But obstructive shock is actually where both of those previous factors can be normal, but you just have some sort of obstruction to cardiac output out of the heart and into the body. And so the physiology here is that you have some sort of blood flow obstruction, okay? So any blood flow obstruction into or out of the heart can decrease ventricular filling. And then likewise, obviously, if you have decreased filling or decreased preload, you're going to have decreased cardiac output. And with decreased cardiac output, we see decreased blood pressure. Blood pressure is the means for tissue perfusion, and tissue perfusion supplies oxygen to the body. So this may be sometimes confused with hypovolemic shock on initial presentation, but we'll talk about how we can distinguish this and how we can treat it. So one type or one etiology of obstructive shock is known as cardiac tamponade. And so tamponade is essentially where you have fluid building up in the pericardial sac. Now the pericardial sac is essentially a small sac around the heart. And so that is not an anatomically correct heart, but you get the idea. So normally there's a small space around the heart, which is filled with a small amount of tissue just to allow it to slide around, or sorry, not amount of tissue, small amount of fluid. And this protects the heart. It allows it to slide around without interference, and normally is just a very small potential space. However, if you have some sort of traumatic or inflammatory process that causes an increase in the fluid around the heart, it starts pressing on the heart and causes decreased ventricular filling, as we spoke about. And so when you have decreased ventricular filling, aka preload, you often have a decrease in stroke volume, and once you're not able to compensate anymore. And stroke volume, as we know, is one of the major components of cardiac output. Another type of obstructive shock we'll talk about is tension pneumothorax. So whereas a cardiac tamponade was looking at excess fluid building up around the heart, tension pneumothorax is excess air building up around the lungs. And so air can enter the pleural space around the lungs, and this is all contained in the thoracic cavity. The thoracic cavity contains both the heart and the lungs, and so their pressures are very closely tied to each other. And so when air enters that pleural space around the lungs, it can sometimes enter but have no means to escape. So if you have a small leak, either by trauma or surgery or other means, air can get into that space outside the lungs, then have difficulty escaping. And so because the interthoracic pressure is increasing in the chest, the lung on that affected side can often collapse down. And so by the lung collapsing down, the mediastinum, or their central structure or a chamber that holds the heart and some other vital structures, can shift away from the midline towards that collapsed lung. And so if you have shifting of the mediastinum, the IVC, which is one of the major blood vessels delivering blood back to the heart, can become somewhat compressed or even kinked. And so when you have shifting of that mediastinum and you have air filling that thoracic cavity and shifting of those structures, you have compression of the IVC and decreasing venous return, and then further down the pathway, decreasing cardiac output, because we know that preload is a determinant of cardiac output. Another type of obstructive shock we'll look at is ductal-dependent congenital heart disease. And so some children are born with essentially cardiac output or blood flow that is dependent upon a normal neonatal structure known as the patent ductus arteriosus. And so this ductus arteriosus is usually open in the womb, in utero, but closes after a couple days of life. And so when patients lose the benefit of this ductus arteriosus, they can have a sudden decrease in pulmonary or systemic blood flow. And so you often think about the patient with an aortic coarctation. They have a narrowing of their aorta, which is the main artery leaving the heart going to the body. And the only way that blood bypasses this coarctation or this narrowing is through the ductus arteriosus. However, when the ductus arteriosus or the PDA closes at 2 or 3 days of life, that patient immediately has an obstructive shock because they have inadequate perfusion from the heart to the body. And so that's a very critical problem, needs to be addressed surgically as soon as possible. Another etiology of obstructive shock can be from a pulmonary embolism. And so an embolism is defined as a clot that forms somewhere and then travels somewhere else. And so the scenario we often see with these patients is they have a DVT or a deep venous thrombosis, and that can happen in their leg or a large vessel farther away from the heart, and then it can become dislodged and actually travel to the heart. And if it's a big enough clot, it can get lodged in the branch pulmonary arteries and cause a sudden obstruction of pulmonary perfusion. And so you can have all of a sudden a ventilation and perfusion mix match. So meaning that your perfusion all of a sudden goes down while your ventilation remains the same. And so you're bringing oxygen into those lungs, but there's no blood flow going to the lungs. And so all of a sudden you're not having oxygen delivery to the body because of this pulmonary embolism. And so the way we diagnose and monitor these patients, again, same principles apply. We get them on the pulse ox, the cardiac monitor, and check their blood pressure. We'll want to get vascular access for resuscitation and get labs if need be. And then really further management of any type of obstructive shock depends on the cause. Whether it's a pneumothorax, you need to do a needle thoracentesis. If it's a pericardial effusion, then we need to have a pericardiocentesis. That's drawing fluid out of that sac around the heart. If it's a pulmonary embolism, certainly they'll need to have that clot either broken down with medicines or removed surgically. And then if they have congenital heart disease, you'll need to fix whatever the underlying lesion is. And so we have to really diagnose and figure out what's going on before we can seek out the proper specialist. Just as a postscript, we'll talk briefly about the Braslow tape, or the length-based resuscitation tape. And so the Braslow tape is a tool that's used in PALS and resuscitation scenarios, which essentially is a long piece of paper that has medicines and doses scribbled on it, as well as sizes of resuscitation equipment for patients. So if you have a child that's laying supine on an exam table and you're able to stretch out the Braslow tape in order to measure their height or approximate their height, you can use that length and that dosing information on the Braslow tape in order to help you with your resuscitation drugs and equipment as needed. All right, we'll just touch briefly on vascular access. Different types of vascular access. The first line is usually peripheral venous access. This is a peripheral IV placed in a small vein, usually in the hands or arms, sometimes in the legs or feet, occasionally in the scalp in the NICU. And it's an easy way to get access into the venous system and provide fluid resuscitation or medication administration. And this can often be done while you're doing other types of resuscitation, including rescue breaths and chest compressions. You'll also see in your skill stations the use of intraosseous or IO access. So IO access is a way to infuse medications or fluids or blood products into the vasculature through the bone marrow cavity. So bone marrow is actually intimately related with the blood supply of the body. And so it's a way to give drugs just as effectively, but somewhat more traumatically, and is only really used in emergencies. So if you can't get a peripheral IV and you're not able to resuscitate a patient, this may be a way to get meds and fluids into that patient. And you'll see how this works in your skill stations. The best places and the usual places that we place IOs are in the proximal tibia or shin bone, sometimes in the distal tibia or femur, and then occasionally in the head of the humerus. And these are places that are flat, they are good targets, the bone is relatively easy to hold down, and we choose them because they have limited, at least relatively less risk of complications. Now, there's different ways to insert the intraosseous needle. You can either do it manually or with drills or powered insertion devices, and you'll look at both of those in your stations. All right, so that concludes our lecture about shock and PALS scenarios. Please let us know if you have any questions, and good luck on your skill stations.